of the things that's happened in the cities of California have voted out fluoridation. That fluoridation is the adding of 1 part per million fluoride to the water supply, ostensibly to reduce tooth decay, although there are no rat studies or dog studies that have ever shown a reduction in tooth decay when you do that. So as Murray said, where's the science? Well, they're adding it in the water supply to get rid of the stuff. And it increases hip fracture, causes an increase in cancer. That's all nicely documented in the scientific literature. One of the things that we're going to do in California, or we're trying to do in California, is to run what's called a proposition. Since 78 cities have already voted it out, we're asking the members of the International Academy of Oral Medicine and Toxicology to think seriously about helping us run a proposition in California to remove fluoride from the water supply. Why is that happening now? Is that the state of California has just decided to make California one of the most fluoridated states after having been facts, but it's kind of a bad reproduction. But read it over, get in touch with me, and let me know if your guys are willing to help and gals willing to help, and put your money where your mouth is, and perhaps we can defluoridate one state, and whereas California goes, the rest of the nation will go pretty soon, and Philadelphia is fluoridated. Introduce Jerry. I got Lee. That voice.
Okay, hope you all had a good lunch. A number of people asked me after, this was just a very brief introduction to what Dr. Gelb does. He will be doing a 5-day course at NYU. For those that are interested, contact the head of the continuing education at New York University School of Dentistry, a fellow by the name of Ken Beecham. And the dates for the next training will be October 19th. At the end of the 5 days, you'll be able to do, or at least know how to do, everything that he was talking about. Okay? If you wanted to, if that doesn't work for you, you can reach Dr. Gelb in New York. He's on, I think it's 635 Madison Avenue, New York City. And he can give you further courses that he's going to give. Mark, are there any other housekeeping? Okay, commercial exhibits. There's a great deal of information that's very valuable up there. In Denmark. After a short term on the University of Minnesota faculty, he moved to the West Virginia University School of Dentistry, where he served as chairman of the Department of Oral Pathology for 17 years. About a year or two ago, he resigned that professorship in order to become the director of the Maxillofacial Center for Diagnostics and Research in Morgantown, West Virginia. He is senior visiting scientist with the Mayo Clinic and is a consultant to 2 VA hospitals, the Pittsburgh Children's Hospital and the National Institutes of Health. He has presented about 600 continuing education courses and seminars throughout the world. He's a fellow of the American Academy of Oral Pathology and is currently a director of the American Board of Oral Pathology. Please give a warm welcome to Dr. Jerry Bouquot.
Sign there. Okay, thank you for inviting me, and I'm very happy to be with this group. I spoke to the Pittsburgh regional meeting about a year ago, I think, and it was nice to actually be in a whole room of people who knew about this disease that I've just been studying and tried to get other oral pathologists interested in. It was a whole different environment from what I had been used to. I would like to explain a little bit before I get too much further into this that when I got involved in this, one of the real centers of controversy was my state, West Virginia, because back in 1979, Dr. Ratner published his paper, and the next month in the same journal, OOO, Dr. Roberts, Alexander Roberts from my state, published a paper on this disease. At that time, we were calling it an infection per se, and we were using the term osteomyelitis, and I diagnosed my first 2,500 cases under that term, osteomyelitis. But finally, I think I can tell the difference between osteonecrosis and osteomyelitis. But because of all the controversy, I couldn't use words like Ratner's cavity or Robert's cavities, Robert's cysts. Those are the terms we used in my state. So I was encouraged to come up with a different name. And this is the name I came up with, and I specifically put the word neuralgia inducing to indicate the fact that this is a disease that produces a pain that's a little different from a typical abscess. Also, a physical cavitation, and osteonecrosis instead of osteomyelitis, because osteonecrosis is tissue, bone tissue death from vascular insufficiency, not necessarily from infection. You will be, it should be coming around to you sometime during my talk, a handout that I didn't quite get to Rich in time, or Mike, I guess it was, in order to get into your notebook. But it is available, and there are extras available in the back. It kind of summarizes the things that I know about NICO, and it's something that has been handed out over 1,000 times. It's been updated umpteen numbers of times. And I'd like you to know that there is a very complete bibliography in here. And that bibliography includes 3 textbooks. NICO is now in 2 endo textbooks, including the 2 most popular endo textbooks, Engel's and Cohen's text. And it is in the most popular oral pathology textbook. And as a matter of fact, it gets several pages in several of those books. So it's not just a fly-by-night disease anymore. And now that it's got a bit of establishment behind it, we can work a little bit out of this whole field of quackery that seems to be surrounding this disease, as well as the mercury issue and others that we've talked about here. While I was there, I did spend almost a year at the Mayo Clinic, and the interesting feature about that whole year was it was nothing but bone pathology. And it was 20 years later to study a bone disease that was of enough uniqueness to interest a lot of people. So that has been a very, very fortuitous thing. Of course, going to West Virginia, where Alex Roberts was another fortuitous thing. I moved to West Virginia, where the facilities were a little bit less than ideal. Actually, this is a picture from Time magazine from China a few years back, and this is my university setting with the university hospital, the old hospital, the dental school is back behind here. And so it's been a nice place to work. I did not leave it because I really wanted to. I just felt that I couldn't get along with the new dental school administration. But I liked West Virginia and Morgantown so much that I decided to set up a center in that area. Well, osteonecrosis goes by different terms. I think all of you have heard the term aseptic osteomyelitis. It's an old term that you won't find in any literature anymore. It went out about 15 years ago. And aseptic osteomyelitis is something that looks like dead bone, but nobody can culture bacteria. It's usually in the hip. We haven't really used that term much in the jaws, but the new terms are these terms. Ischemic osteonecrosis is the pathologic. That's what goes on a biopsy report. It's the pathology term for this disease. When it occurs in the alveolar bone, this is the term. When it occurs in other parts of the body, it may be called avascular. It is not really avascular. The blood supply partially gets totally cut off in small areas and at separate periods of time. But it is not only an avascular disease. So the term ischemic is becoming more and more common in all. It's so unique to the body. It's, to the jaws. We've known about a disease called avascular necrosis of the condyle, which causes arthritic types of changes in the condyle. We've known that for a long, long time. And believe it or not, that has the same amount of controversy surrounding it as NICO has. But the number one place for this disease to occur is in the hip. Here we have bilateral involvement. 40 to 80% of patients with osteonecrosis of one hip will get osteonecrosis of the other hip within 10 years if we follow them for a long enough period of time. And NICO also is a disease of multiple quadrants. Keep that in mind. It's got to be a systemic problem if we're getting these bilateral disease processes. In the hip, it's a much more severe disease in one respect. This is the #1 weight-bearing area in the human body, and so if we have dead bone, it eventually collapses. And there's no way, because of the poor blood supply, there's no way to heal this bone, and so this is becoming one of the major causes of hip replacements. A lot of these bad hips are still being called arthritic hips, but as medical pathologists become more and more familiar with what this disease looks like and what changes there are between this and arthritis, we'll be seeing more and more diagnoses of this. I have had at least 2 that I can remember. 2 hospital pathologists have sent me hip lesions asking me if this is what I see in the jaw, because they haven't got the foggiest idea what it is. That's how little this disease has been taught to the medical pathologists. And to the oral pathologists, I was the first one probably to ever use the term osteonecrosis. It's not a single disease. There are multiple underlying causes, and there are multiple ways that it can present. Generally, of course, it's going to be in a bone. The pathology, however, what we scoop out of the jaws is fairly localized. The trouble is it can be going on in multiple local areas throughout the body. So a lot of the literature a lot of what we understand about this disease, we only know because there's so much literature in the orthopedic surgery area. There are over 100 papers on osteonecrosis published every year on this disease. Well, we're very much used to working in and around the mouth. The big question I always get is, why haven't we seen this disease before? Why all of a sudden is there this huge epidemic of NICO? Is it a huge epidemic? I, of course, know of every NICO case in West Virginia because of the controversy that has surrounded it and because every oral surgeon in the state sends, except for one, sends their tissue to my biopsy service. I have also taken the trouble to go through 5 counties in northern West Virginia, the hospital records, to see if anybody there had osteonecrosis, including osteomyelitis of the jaws. I looked at all the tissue samples. I think I have a good feel for how many biopsy-proven cases of NICO there are in this population of about 300,000 people, this 5-county population. In that group, this is primarily a female disease. In that group, 1 out of every 1,000 adult females has NICO. And those are just the ones that have been biopsied. I can't imagine how much more common it is. That makes this disease at least as common as lichen planus, and all of us know, we've been taught everything there is to know about lichen planus. I see lichen planus every week. I see or talk to somebody with NICO on a daily basis, but of course that's a national level, whereas lichen planus is mostly in-state patients. So this disease is not a rare disease. Why haven't we found it before? Well, I'll get to that in a little bit. The problem with osteonecrosis, you've all had your feet fall asleep. You've all had an arm fall asleep, those of you who are older anyway. As you lose the blood supply to an arm, when you cross your legs, you lose the blood supply to the leg. That's not a pinched nerve that's causing your foot to fall asleep. That's just you cut off the blood supply. When you take that blood supply, put that blood supply back in by relieving, taking the legs apart or the feet apart, you get fairly intense pain. That is a very mild example, if you will, of the kind of thing that is occurring, I think, in the jaws, except that we don't have soft tissue and no other bone has any kind of major sensory nerves in it, with one of the most, the most complicated nervous systems in the entire body, and you've already been told how important that particular nerve is to the rest of the body. So if we have a cutoff of blood supply, and it happens, is different from the other osteonecroses. The other osteonecroses don't have trigeminal neuralgia pain. About 10% of NICO patients have trigeminal neuralgia pain. Initially in my population, I had half and half. Half of them were trigeminal neuralgia cases. If you think about the atypical facial neuralgias, however, they think about this. They describe a pain here 1 week, a pain here the next week, a pain down here the third week, and they're all thought to be neurotic because they're looking for attention from doctors or whatever. But if you have a problem that is cutting off the blood supply in a small area here 1 week, maybe you get another infarction in another area another week, another infarction in another area another week, that could be the same explanation. And a lot of NICO patients have fibromyalgia, and they have aches and pains in other parts of their bodies. We are talking about a systemic disease. This is above and beyond the kinds of things that we're thinking of with the bowl meridians and things of that nature. And I think we're going to try to see if there is some credibility to those meridians. But above and beyond that, we're dealing with not a local phenomenon. It's a systemic disease. We're just trying to clear out an area that has dead bone. It's never a good policy to keep necrotic tissue in the body because of immune responses, if nothing else. So if you think about not trigeminal neuralgia, but atypical facial neuralgia, they describe their pain as referred to different places, maybe. It moves around. People with this disease in the hip describe it as a deep, boring ache. They describe it as sometimes in the groin, sometimes above the hip, sometimes behind the hip. It moves around, and it interferes with function. A lot of NICO patients have TMJ problems because of the localized pain. If you read about the pain in patients in the hip, and then look at the descriptions of patients with atypical facial neuralgia, it's almost the same disease. Almost the same. So we shouldn't be too surprised about those. The ones that surprise us are maybe the trigeminal neuralgia, and maybe those are areas where this infarction occurs right around the nerve. I have no idea exactly why we have all of these different pain syndromes in NICO patients. Referred pain is something that Bob is going to talk about after me, and he knows a great deal about it, more than anybody I know of, and I think it's a key feature to diagnosing and successfully treating this disease. If you don't understand, you really shouldn't be dealing with this disease, and it wasn't until I met him and started talking and learning from him that I was able to diagnose almost all of the NICO cases that come to my office. I still miss a few and have to send them off to him. Another problem with this is the person with the least expertise of oral pathologists out there, and oral surgeons, oral pathologists who have never diagnosed it, oral surgeons who have never treated it, they couldn't find it, they say it proudly. I've never found one of these. And that is not an attitude that I'm used to. I am an oral pathologist. We debate. We don't just say, I believe this or I believe that. We debate. We've got a piece of glass, and we can point to something on that glass. It was only because of NICO that I got involved in the chronic pain problem, and the political and social overtones of that have absolutely amazed me. Absolutely amazed me. I think it's because of this. I was called in by all 6 of my deans, all of the 12 department chairs in 1991, 2 lawyers, and I was told, you cannot do research on NICO. The disease does not exist. I was told that. No notice whatsoever. I just walked into a meeting I thought was a routine meeting. And I just went one by one around the room. Have you diagnosed this? Have you looked at any slides? Have you diagnosed it? Have you looked at any slides? And of course they had to say that I knew what I was talking about under the microscope. And so that became a non-issue, and I literally walked out on all of my deans and the other chairs. And don't get me wrong, I have been extremely happy at West Virginia University. I think it's been a great little dental school. So it's not that I haven't gotten along at all, but this particular meeting was just a little too much, and it's because everybody thought that they knew more about the disease than I did. Well, that turned around to the point where in 1994, a master's thesis in endodontics was published on over 2,000 cases of NICO. And that school, the faculty is very proud of the fact that this is where NICO is being understood. So it's changed dramatically. Now maybe everybody is an expert. But because of this phenomenon, I felt this. I've almost wanted to follow Lefty's rule. If you don't throw it, they can't hit it. And a lot of us, I think, tend to hide in holes, probably not too many. I think the stage of ridicule Now we're just on the outside edge, the leading edge of the violently opposed, and I think another year or two, and it won't even be violently opposed. And I'm doing my very best to keep this on as scientifically sound a footing as this organization represents as possible in order to diffuse some of these quackery charges. I certainly think within 5 years it will be accepted as self-evident, but probably in the oral path community, after case, we're going to start teaching this to our dental school and medical students because we want to find this disease as well. So it is turning the corner. The question of does NICO really exist is obviously out of the question now. Well, I think probably the reason that this is no longer a question is because we've had people like Ratner, like Roberts, like McMahon, like several people in this room who just haven't accepted other people's opinions and when told to stop doing this have continued on because they're trying to help patients. So, I've explained what this disease is essentially all about. Now let's get into some of the more specifics. This is very important. Ischemia means a slow drop-off of blood supply to an area. Infarction, of course, is a rapid cutting off of blood supply to an area. This is a disease with both features, and in some individuals, we only have microscopically ischemic effects. They only have a sluggish blood flow, and I'll show you that accompany that. In others, the infarction is the dominant feature. And these are not major infarctions. These are micro-infarctions. That's a term from the orthopedic literature. There are all kinds of names that were made up for this disease in the orthopedic literature. Microinfarction is one. Cavitation is one. Cavitation was a term made up for the hip lesions, which had hollow spaces, many of them, and it was made up in 1930 by the most respected of the bone pathologists in the country at that time. Fortunately, I guess that's why it was accepted. But these are the kinds of things that lead to ischemic changes, sort of like crossing your feet and cutting off the blood supply. There is a disease called Caissons Disease. People who dig tunnels for a living are going in and out between variable pressures, and that causes real problems. The pressure inside the bone can't equalize if they do this too fast, and it can cut off the outflow of blood to the bone, or from the bone. From the bone. Think about a tooth. I don't think there's anybody in dentistry that would not accept the fact that if you smash a perfectly good, viable tooth, there will be edema of the pulp. The veins out of that pulp will be collapsed because of the edema, because of the fluid pressure in that pulp, and the tooth could die. That's taught in every dental school, very well accepted. Well, the orthopedic surgeons have accepted for years that the same thing happens in bone. But in our dental literature, I've seen specific statements in textbooks. This cannot happen to the bone. But it does happen to the bone. And one of the things that makes it happen is changing air pressure. In Japan, there are people, pearl divers, who use the headset and go deep sea diving. 50 to 80% of them eventually get osteonecrosis. People who dig tunnels, 30 to 50% of them eventually get osteonecrosis, even if they don't get the nitrogen bubble disease, just from routine working under those variable pressures. When we put corticosteroids into people's bodies, it increases the size of fat cells, and in bone it causes an increase in fluid pressure, intercellular pressures. And as a matter of fact, in some long-term corticosteroid patients, osteonecrosis in corticosteroids. And there is a case out there that talks about a single Medrol dose pack, a 1-week course of not too high dose of prednisone causing osteonecrosis. The disease hits a few weeks, or a few months, after the treatment starts. There's a few people, but it takes a little time to develop. People who are malnourished or alcoholics, the alcoholic group is a prime group, always has been, for osteonecrosis. If you have too much or too little estrogen for two different reasons, you can end up with this disease. And Bob is going to talk about thrombophilia, fibrin clotting, and those kinds of clotting disorders that we believe now is the primary cause of most of these diseases. People who have collagen diseases, people with lupus, people with scleroderma have more osteonecrosis than other people. It may have to do with this antibody more than anything else, and Bob will talk about that. There are, in the orthopedic literature, there are a few studies that say that maybe tobacco is important, but we don't really know how important that is. So those are the causes. These are the different names that are out there. Aseptic osteomyelitis, aseptic osteonecrosis, idiopathic osteosis, chronic osteitis. I think, Adirana, you used the term chronic osteitis. That was a term for NICO, coined by G.V. Black in 1915 actually. And so this is not a new disease, it's just one that we've kind of forgotten about. Avascular necrosis is a commonly used term. Dysbaric osteonecrosis is in the deep sea divers. And of course, we've always had osteoradionecrosis. We've known that people with irradiated jaws, we call it osteonecrosis. We don't call it osteomyelitis. We worry about a secondary infection, and the reason we worry about that secondary infection is we know that this bone is not able to withstand any kind of bacterial onslaught. Problems is, I'll get through to some x-rays in a little bit. You can't see it. I can find these now because Roberts, the fellow I learned from, found it through the x-ray. And he didn't realize, I know he also found it by palpating and by asking questions, lots of questions of the patient. Where do you hurt? What happens? What was it like last week? What do you think it was like 6 months ago? That kind of thing. But when we take x-rays, especially something as crude as a Panorex, which is what the oral surgeons usually use for their work, it just doesn't show up. I can see it because I know what to look for. I have a huge amount of suspicion when I get an x-ray. So I'm always looking for this, missing it. When I first started looking at Dr. Roberts' x-rays, I could only pick up on maybe 10%. So they were only the obvious ones, the ones that everybody in here could pick up on. Now, because of all this, thousands of x-rays that I've looked at, I can see it in about 75-80% of the cases. But there are still 20% that are totally invisible to me. And this is one, the lesion. I saw this particular surgery, so I know that the arrows outline the lesion. But I know now that when we see these vertical trabeculae, those are either abnormal trabeculae or remnants of old lamina dura, and I kind of wonder if this has a little bit of a tooth look, and maybe there was a little height, but that tells me that there was ischemia going on when that tooth was pulled. Therefore, either ischemia or low-grade infection. That's the only explanation for a remnant of the socket to still be in place 6 months or certainly 12 months after the extraction. There is no way. We see these all the time. You see them, and those of you who are in general practice, general dentistry, there is no normal explanation for that. Just because, well, the average person, the average male in this country over 65 has atherosclerosis. That doesn't make it normal. It's a disease state. And the only explanations that I have been able to find for this phenomenon are low-grade infection and poor blood supply at the time of extraction, and probably for time immemorial, any time thereafter. I have seen the same things, and I'll show you some later on, 20 and 30 years after the extraction. Another thing is, we've had such a great reason for explaining pain and dead bone. We've got all these pussy teeth. The teeth, of course, make NICO probably the prime example of osteonecrosis in the body, and I am convinced that it is already the most common form of osteonecrosis. And it is something that we've been missing only because we've all been carpenters, and we've only had hammers, and we look at things like this and we say, oh, that's normal. I've seen dozens of those. Why the jaws? I think I've explained. We've got the nerves there, and we've got the teeth there. Two of the most unique features of any bone in the body. We have been finding NICO in nasal bone. We've got a few in people who had nasal steroid sprays. Kind of interesting, isn't it? NICO, the ENT docs know about osteonecrosis around the external auditory canal. They even have a special name for it. So it is in the head and neck bones. And I think, of course, because of the tooth and these kinds of problems, we're getting more and more of we have a ready explanation, in other words, for this being a common disease in the jaws. I am actually amazed that we don't get more of it. If we have pus at the apex of this tooth, where's it going to go? Well, probably up here. It'll drain through the chin. Maybe it'll drain through the lower alveolus. But if you had a bone, a long bone, and you put the same amount of pus in that long bone, it will travel up and down the bone marrow and fill the entire marrow space with death and destruction before it finally breaks out. I'm exaggerating quite a bit, but it travels the path in an abscess tooth. It takes the hardest, shortest path directly out. Why is that? I have no idea. But we should be having osteomyelitis every day of our practices. We should. And if you read the literature from 100 years ago, they did. They had osteomyelitis. We just are better nutritioned, I guess, than the old days. And we've got antibiotics to help. So, this is a disease that affects the jaws, and it is not going to affect everybody because of these clotting problems and because of the different types of disorders that can cause clotting problems. And I'm going to leave all that to Bob McMahon. He's going to pull here about clotting. But as a matter of fact, we have been working with a fellow named Gluck at the University of Cincinnati. We published our first abstract last year on this, looking at some of these small clotting problems that produce microinfarctions, not massive heart attacks, but microinfarctions. And it's probably one of the most exciting things, I think, going on in dentistry today, even though it's not well accepted. Well, if we look at the kinds of coagulopathies that have been published in the hip literature, we'll find pretty much the same coagulopathies in NICO patients. Is it very common in NICO patients? Bob will tell you that we've got something, I think it all adds up to about 88 to 90%, whereas in the normal population, but less than 8% would have this disease. This is all very brand new stuff. It's only something we were thinking about last fall, and it's very interesting. I've read literally thousands of papers on osteomyelitis and osteonecrosis, and it over to the osteonecrosis, which I knew very little about, had never seen a case of up to that point. I had seen all the NICO cases, I was misdiagnosing them. Up to that point, I was simply flabbergasted, because when that was talking about the disease that I understood by that point. So it was a very dramatic, almost like a religious experience, the fact that do something. I didn't just pick myself up. Well, this is a clotting problem. Where do we see the clots? Biopsy is not the way to see the clots, but now that I'm attuned to it, I do see fibrin aggregates. See this background film. This is all fibrin, and it's not so unusual to see tissue fragments coated by fibrin. Is made once the fluids from the vessels get outside the vessels. So that's not so unusual. But to have this number of clots, every one of these pink dots is a fibrin clot. And to have them all kind of coated together here is very, very unusual. And that's what I see. And I see it in maybe 1 out of every 8 cases. But still not a way to diagnose this stuff. If we find it out here in this fibrin coat, that could be a normal state of events. But when we see it here in the hematopoietic marrow, it's just sitting, there's no infection going on here, there's no surgical interruption, it's just fibrin sitting in the middle of the bone marrow. There is no physiologic explanation for that. This has to be a pathologic state. Something is making that fibrin form prematurely. And here's another one, another group. Unless there's damaged endothelium or unless there's something going on in the vessels themselves that is producing this kind of aggregation. And then there are some beautiful ones I've seen. Here's the tissue fragment edge, so we don't know what happened beyond in triple ovaries very soon. A fibrin aggregate that's actually closed off this vessel, and look how wide that vessel is. It's probably 40 times normal thickness, probably from backflow pressure. I'm just guessing, but probably from backflow pressure, and that guess is based on the literature in the hip. And here's a close-up showing this fairly vessel. And here's one that happened to get caught in an area of furcation and plugged probably upstream, but the tissue edge the fragment edge was right. The pathophysiology, with Bob's help, his understanding of physiology, and what I understand through the pathology. And this is a dead artery. It's probably 4 times thicker or larger than normal. So there was enough backup pressure here to produce, the picture's fuzzy. These are all decalcified tissues, and so some of them do appear fuzzy. And so the backup pressure was enough to create enlargement of the arteries, not just the veins. Now that's a little different, isn't it? Probably the fluid outside the vessels crimps off, collapses them so that we can't get blood flowing out. This is a different phenomenon. Not everybody with NICO has these clotting disorders. There are different causes: estrogen, corticosteroids, collagen diseases, and all of those have to be looked into in these patients. But I'm not sure if Jaffe's precept is really true, because almost weekly we're finding more and more new revelations about this particular disease. But still, to this date, it's impossible to know what we don't know. People expect us to know all the answers to this, and we just don't know. It's a brand new disease, brand new understanding anyway. We're in this stage. We're observing by just watching, and we're finding out a lot just from that alone. Well, another reason we've not been able to diagnose this is there are no surface changes. You look at the alveolar bone, you don't think of infection. The tooth is gone, or you did endodontics and then pulled the tooth after the endo failed, and the pain is still there. Well, you call it phantom toothache. If you call it atypical facial neuralgia, if you call it trigeminal neuralgia, you call it phantom toothache, you call it vascular headache, whatever the pain condition is produced from this focus of dead bone, as soon as you give it one of those pain diagnoses, the docs quit looking deeper. They just stop. 2 months ago in the ADA journal, the same journal that I review for, and recently turned down a great autopsy case of NICO, the first one, presented a case, 18 cases of NICO, but nobody went into the bone to find out exactly what it was. So they weren't observing, and they weren't watching. And I guess I wasn't either for most of my life. As time has gone on, I have found, as my base of contributors has expanded, I'm pushing close to 4,000 specimens now of this disease from 34 states, 3 Canadian provinces, 3 European countries. It's kind of an overwhelming thing, really. But about 10%, I would estimate, of my cases, according to biopsy reports, do not have pain. I'm recommending that if anybody sees an X-ray change that seems to fit this, go ahead and remove it, because nobody is going to say, yes, you should go, or medically sound. And so there's good justification for removing the tissue, besides which you don't know what exactly it is until you get a biopsy report back. And so I am encouraging people to go in and into these, what I used to call silent NICOs, but until 18 months ago or 2 years ago, I had never heard of such a thing. Every single NICO case I knew about, and this is probably 25, not only are they asymptomatic in the hip, so the orthopedic surgeons have the same problem we have, but look at this. X-rays. Have you ever known a disease? This is the staging protocol for osteonecrosis of the hip. About 3 or 4 years ago, they put a stage 0 in, because there were so many that were completely negative by X-rays, CAT scans, and MRIs. Completely negative, show up radiographically. You have 2 lesions here that are the same size, but one has a fuzzy outline and one doesn't. We can't see the one with the fuzzy outline. And the same goes on. This is from the ADA journal, I think in 1964. Somebody just went in, took a periapical film, went in and mechanically, it's a dried skull, mechanically broke all the trabeculae, glued everything back together again, took a periapical, and to me, I can't see a bit of difference between the before and after. You have to lose 40, 50, 60% of the disease of the cancellous bone. It's a marrow disease primarily. And so it shouldn't surprise us that we don't pick all of these up radiographically. Well, let's look at some of the radiographic changes. Some of them are very obvious. This looked like what I would have called osteomyelitis with pus draining, but this was just a fibrous channel, and clinically there was nice pink. There wasn't even a soft area, so there was no indication of a fistula to the outside. And this was one of my first cases. When I look carefully, I can see the lamina dura up and down. I call it laminar rain because in multiple extraction sites it looks like a rainstorm or hailstorm. So there was ischemia probably going on many, many years ago when the tooth was extracted, but these were obvious enough for even me to see in my early days. And we just unroofed them and then popped some radiopeg material, plastic material, I believe, just dropped them right in the hole. And we haven't touched any of that. These are totally hollow spaces. And many of them are very subtle, especially in the upper wisdom tooth area. You can kind of make out in a very dark room a little bit of a scallop border here. And here's the whole lesion. This is an x-ray that's in your handout, and I put an X right here to show where the lesion was with some arrows right here. But it's easy to spot if you're into it, but you're just going to miss it if you're not familiar with this disease. And there are some where, I mean, this was a NICO that was literally big enough for me to stick my small finger in. There have been 2 maxillary and several mandibular ones where I could do that, and this was one. And I was expecting involvement right here where there's kind of a triangle, but actually it went all the way back to the hamulus. And this is a disease that proves Miller's law. Last week I used a variation of McMahon's anesthesia technique, and I was putting a drop of anesthesia right over the mandibular third molar from the facial side. And I try to get right on the bone itself when I do that, and the needle just went right on through. I had to feel the lingual side because I assumed that the needle had gone out the lingual. It hadn't, but it shows you how mushy these things could be, and on that case it looked perfectly normal. Plus, the x-ray appearance doesn't really tell you how large it's going to be, not in my experience anyway. It'll tell you that there's something unusual there. This, you can see, not only has remnants of teeth that were removed decades ago, but it's even got the Jacob's ladder, the kind, there's no physiologic reason for horizontal bony trabeculae to be in the jaws, not after the teeth are out. But this bone hasn't changed at all. And if you look carefully, you can see this bicuspid site. You see a little remnant of the old lamina dura. And here's a remnant of an old lamina dura. And if you look at this, at first you would say maybe it's not too abnormal, but it has what the orthopedic surgeons or radiologists call ghost marrow. There's a slight haze. It's kind of a black background with a loss of the normal trabeculae, but there's a fog over the area, just a very slight grayish appearance. And since I read that, I've been looking for it, and it's in the mandibular posterior area. It's not such an unusual finding. And this is in the pathology textbook, which happens to be our textbook, and you can see the laminar rain as well as the horizontal, and this was, I think, 22 years after the teeth were extracted. If you look carefully, you'll also see ghost marrow. See it down here? And look at this. We've got, here's some laminar rain, the old remnants of the sockets. Sometimes when we go in, we find those are just pure, dense collagen. This is the inferior alveolar bone, or the inferior alveolar canal, the bony wall of the canal. Where did it go here? It's gone. Avascular bundle. And so loss or breakup, little chips and pieces out of the canal wall itself is a sign of this disease. And here's one that was a little more like routine osteomyelitis. It was one of my early ones again, so I was able to pick it up. And I've shown this one to a lot of people, and they've all been able to see something. This was one that had a little bit of calcification. It is true, if ischemia is very mild, instead of knocking out the osteoblasts, it stimulates them to lay down new bone. And I've been finding NICO in over half of the tori that I get. Now that I'm looking at it, you know, we could never understand why tori continuation might be. These are areas of ischemia. Why the ischemia, I don't know. This is only an early observation. but to find it in any torus conditions. I have found some NICO within condensing osteitis, so if you have a symptomatic condensing osteitis case, there may be bone death sometimes within it. This is kind of, you need a good case to find it on the Panorex. The laminar rain is maybe a little bit visible here. The occlusal films, this is the only one where I found MRIs, if they're done right, may be able to pick something up, but I don't think MRIs are worth doing in this disease. This is a disease that's actually best that wasn't even present on the other two. That I just happened to hit on by accident, but it's something I use in almost all of my cases now. Disease exists, and look beyond the name atypical facial neuralgia or anything else. Probably the best test after periapical films, and one that is good to use for political reasons, because if you see a hot spot, then you have something there, and that justifies asking. 80% of NICO cases are positive on a technetium-99 scan. When you use it, there are lots of different technetium scans, but you have to use the phosphate scan. There's another one that we're just looking at, silver colloid. Maybe Bob will mention a little bit about that, but it's got to be the phosphate, otherwise it won't really pick these up. And these are cases, here we see some frontal sinus involvement. Involvement here. This is 3-quadrant involvement, and there was nasal bone involvement, if I remember the case right. These are people who were totally negative on every other image. And as a matter of fact, this was all read as normal. The radiologists have been taught that if you see a hot spot on a tech scan and it's in the jaws, you don't even mention it, because it's perio. Everybody has perio. Everybody has pyorrhea. And they just assume that that's what it is. And so I've taken to asking for the scans, and Bob McMahon does the same. Well, before I quickly get through some of the histology here, I wanted to show you a little bit about what we find clinically. Most of these patients are 40 to 60 years of age. We've got a new case now that's down to 16 years of age, and we've got a 94-year-old patient. 2/3 of them are females. That causes a real problem because the docs automatically give them these pain syndromes and assume that they're neurotic if they don't fit into a classic pain syndrome. Of people in this audience who believe that endodontics is the cause of NICO, and as a matter of fact, George Meinig said that in his book. He called me one night, first time I'd ever met him. Now that I know him, I really enjoy him. But he asked, he had seen my handout, and he asked if he could put it in his textbook, his second edition of the textbook, and I said, fine. Well, he did that. He just Xeroxed it and put it in as a chapter in his text. There is no telephone number for George in that book, so I get a lot of calls. But as part of the ad in the front couple of pages, he has a quote from me saying that NICO is produced by endodontics. I don't really believe that. Any local inflammation, whether it's pus, poorly formed endocase, extraction, can cause a local inflammatory response, and any inflammation in somebody who's got these underlying clotting problems can be all it takes to cause local clotting in that site. So it's not specific to endodontics. But most everybody has a history of extraction, maybe with a dry socket. Endo is done, sinusitis might be in the history. But there are too many of them with nothing in the history at all, sort of spontaneous cases, and I think they're the ones that prove the point that this is not so much caused by dental processes. Can do it as well. So most of the people that we are dealing with have had neuralgic pain for at least 5 years and up to 32 years. They've been in pain a long time. These are very seldom short-acting pain patients. By the time they get to me, they've really been around the block. I never have diagnosed trigeminal neuralgia or atypical facial neuralgia in my life. I've made a presumptive diagnosis and sent the patient to a neurologist or a neurosurgeon, and they make the diagnoses. But NICO, once NICO came along, everybody had already been diagnosed. They'd already been to the neurologist and had their chemicals, and they'd already been to the neurosurgeon and been told, we can't do anything for you, or maybe they had some brain surgery. So These are people that have, by and large, been really around the block. I went through a short series of medical records and found that the average number of doctors seen for the facial pain before they got to a NICO surgeon was 32. And I know one patient from Philadelphia, as a matter of fact, who happens to have enough money to do this, but she's been to over 300 doctors, and she's only 32 years of age. Over 300 doctors for this disease. And she has probably a very bad systemic problem. It's not just a local jaw thing. A third of all the NICO patients have more than one site, actually more than one quadrant involved. And look at this, 1 out of every 10 loses its blood supply. It doesn't all die at once. It kind of, the cells, some become very small, some remain normal in size, and then there's a fibrous network that forms between them. And it looks a lot like fibrous osteomyelitis, and that's why we were all diagnosing this as fibrous osteomyelitis. But you'll see that these are hallmark changes that are present in ischemic marrow even before we get any infarctions. And this is in a paper that I'm about to send off, but this is essentially the master's thesis, the basis of the master's thesis done by Mark Byron, who's an endodontist. That was presented for the first time at the American Academy of Oral Pathology today. Well, we have to go from normal. This is normal fatty marrow. You see how small the sinusoids are, the capillaries, if you will? Very tiny little things. And all the fat cells are reasonably the same size. Maybe some are 2 or 3 times variation in size, but you don't get some very small ones, and then, whoop, that's a vessel, and then some very large ones. And you don't have anything between the fat cells. I mean, this looks like if you held the glass up to your eyes, you wouldn't even see a lot of this marrow because it's just, all we have are thin fatty cell walls. This is what happens with ischemia. We get a bunch of small downsizing, if you will, very small fat cells, and then we get this loose, fibrous, kind of grainy material in between. And there's no explanation for this. The only explanation for this particular appearance, by the way, is ischemia. I didn't know that for a long time. But here's a picture from a rheumatology textbook talking about osteonecrosis, and you can see the same kind of fibrosis in the background, and the fat cells haven't quite degenerated. But then we get to this, maybe we can focus this a little bit better. You see not too abnormal fatty tissue. Down here we've got a problem because we've got a bunch of fat cells that maybe all died together and they pooled their liquid fat together. We've got some of the fibrosis up here that I mentioned, and we have a huge cyst up here that may or may not have been the edge of a cavitation, or perhaps it was the edge of one of these phenomena. They're called oil cysts. But if you look, you see there's kind of a gritty, this has a different texture, grainy more than fibrous, and all of these dots are remnants of red blood cells. This is a very recent infarction. This has happened within the last week or 2 weeks, and the tissue has died, and you see this is already probably several weeks old, and there isn't a single inflammatory cell attacking this tissue trying to get rid of it. I have no idea why the body does not recognize this as something to be gotten rid of. But inflammation is not part of the NICO histology. As I say that, I'll point out this is one of the textbook cases, because in some individuals there are all of these black dots are lymphocytes. You see some of the fatty degeneration here, and there's a nerve. The black dots are all inflammatory cells, and there is an osteomyelitis overtone to that particular case. When that comes along, I call it osteonecrosis with osteomyelitis. And every once in a while, I'll find wide, very thick, for a blood vessel, very thick arterial walls, which tells me that there probably is a long-term, long-standing increase in arterial pressure. Here's taken from an old textbook. You see, this is a blood vessel, and here's one filled with material that they used actually to cause clotting. But the background is just this fibrous tissue. Nothing very special. That's why it's hard to get pathologists interested in this stuff. But then we get to these kinds of things. Remember that first picture, how big a sinusoid is? Well, how big do you think this is? 50, 100 times the body. Osteonecrosis does not seem to cause fat globules to go all over the body. That can be a fatal situation, but the vessel is. And as time goes on, we presume from the hip literature that this backflow causes a generalized increase in pressure throughout the system, and the pain becomes more and more intense. In the hip, one of the ways that some orthopedic surgeons diagnose this disease when it's invisible on the x-ray is to inject saline into the hip. If there is a problem with outflow, the increase in pressure is maybe 3, 4, 5 times higher than normal, and there's an intense pain. We're talking about the hip here with no major sensory nerves, but there's an intense pain just from that increase in pressure. If there is no intense pain, that tells the surgeon that, well, this is probably okay because the water's leaving as fast as I can inject it. That might be something we might try in the jaws, but we don't really know about that. This is from the literature. It shows that same kind of fibrosis and thickening of the wall around an old arteriole. It's kind of degenerated in the wall, actually. But every once in a while, I mean, this is not going to excite any pathologist. It looks like the inside of an irritation fibroma. Nothing's more boring to a pathologist than that. But you won't find very many blood vessels around here. These, I think, are the orthopedic surgeons call these fibrous islands, but I think most of the time when I see it, it must be a socket that has fibrosed in. And I think we have already talked about this stuff. In areas after we get this kind of necrosis, where we just have pale staining old red blood cells left behind, and this all should look like this kind of hematopoietic tissue. We just have a few remaining viable hematopoietic cells left. But since we have a lot of fat in our particular bones in the age group that we're talking about, we have a bunch of these fat cells that just die, and then they pool their blood, or they pool their fat as liquid fat, and the surgeons look at it. They can see this. Some of them put on the report it looks like chicken soup because they see the little bubbles. And I've talked to people who do implants, and they say, no, I've never run into NICO. I say, well, what do you do when you see the little fat bubbles on top of the hemorrhage? Oh, well, we just close it up. We don't put an implant in that kind of bone. So they've been seeing it, they just didn't diagnose it. And then this is the edge of a huge cavitation in an autopsy case. It was very, very large, way beyond what we would see microscopically. And you can see the edge of that is perfectly normal. There's no fibrous marrow, there's no artery cells at all. We have a few remnants of maybe some hematopoietic cells, and that's it. And this is from the only autopsy case we have so far. This is the posterior, about the second molar, third molar area of the mandible. You can see that the bone is totally, I mean, there is no canal wall in this place, and here is some abnormal tissue that's actually putting some pressure on the nerve itself. And the cavitation here was totally invisible radiographically. A lot of old hemorrhage. I told you it looks like a blowtorch. Not this one. This is one of the wet lesions rather than the dry lesions. And the edge of one of those little cavitations is right here. A little bit of fibrin maybe, but the rest of it is just normal. Here's pure bone on the edge of a cavity. There are only 3 diseases I know that create cavitations in bone. One is NICO. The other is traumatic bone cyst. We're all familiar with that. And the third is a little cyst on the end of the long bone in a joint that's got arthritis, degenerative arthritis. Those are the only 3 things I know that will produce air-filled spaces in bone. And guess what? If you look in the orthopedic literature, from the radiographic appearance, they've typed all of these, and type 3A and 3B are cavitations. The last thing I'd like to point out has to do with all of the bone. What happens to this dead bone? It just falls apart. The orthopedic literature has a term I thought was great, instrumentation in my samples. And so I'm not dealing with that kind of a thing. Plus, this was even seen in an autopsy case But the fat cells, there is a way that if you've ever made soap, my family used to make soap back in the suburbs in Minnesota, and it would go rancid sometimes, and it actually would calcify. Saponification, calcific saponification, calcific fat. And if you look in the orthopedic literature, you find the same kind of mushy areas that we find. And these things, I call NICO globules, but they're right next to normal fatty marrow, hematopoietic and fatty marrow with absolutely no inflammatory cell response. So this is the autopsy case. I don't think since we're running out of time, I won't take it any further except to say that this is very much true for this disease. I've had to study and Bob McMahon has forced me to study neurosurgery, neuropathology, neuroanatomy, all these clotting problems now, so hematology is part of it, bone pathology. Let me get to it. Oh, I did find the real cause of this. This is little Nico. This is from the autopsy case. I had to put a little face on it, but here's some of that mushy bone. Here's a bunch of the fibrosis. And this is called a wormhole. A wormhole, only in osteonecrosis. It's a place where probably this vessel clotted off and died back, and there was not enough new blood supply to get remodeling. So these wormholes, you can see them. You can stick an explorer in them, and they probably will travel between two sites of NICO. I thought initially, what's the best treatment? Antibiotics will help the pain. I use that as a diagnostic thing. If it helps the pain somewhere there, I've had surgeons tell me they had to jump back because there was so much pressure that all this necrotic crud flew out at their faces. So that makes some sense, but we haven't really studied it. Curettage, just do what G.V. Black said, go in and remove everything that looks abnormal. I don't know of almost everything I look at. Every once in a while I'll get something that's 90% normal and 10% NICO, but almost always it's 90% NICO and 10% normal, or no normal at all. These people are not doing damage to the bone. The damage was done by the disease. Hyperbaric therapy maybe is of some good. This is stanozolol. This should be a Z, and that's a steroid precursor that is good for some of the clotting disorders, and Bob will tell you about that. But I recently published in April in the Oral Surgeon's Journal a follow-up study of 103 NICO patients. They had multiple surgeries, many of them. One of them had as much as, I think, 10 surgeries at one site. One had as many as 13 surgeries in all 4 quadrants total. But eventually, 5 years after, on an average, 5 years after their last surgery, eventually 73% felt their disease was over. They might get a little twinge, they take a little aspirin or some antihistamine if it's a sinus lesion, and they're okay. They're not taking any medications, they're not looking for any new treatment. They consider themselves just fine. And it's the other percentage. Some are helped a little bit, get the pain down to 50% maybe. But what happens to this 27% that doesn't get better? They go to the pain clinic down the street. And after a while, that pain clinic only gets 6, 10, 18 of your failures. And they think you don't know how to do anything. And I think that's one of the problems with the chronic pain picture, if you will. The whole arena, all the failures go to the guy down the street. And the guy down the street only knows of your failures, and behind your back, he's calling you a quack. That's just my observation as an outsider in this whole business. And I don't know any way to get around that. But it sure would be nice if you could sort of pass your successes down the street. And the way to do that is to do studies like this. Probably the last point I'd like to make is it didn't make any difference whether it was atypical facial neuralgia or trigeminal neuralgia. We were treating osteonecrosis. We were treating dead bone. But lo and behold, most of these neuralgic pains were gone and remained gone for 5 years or more, in some cases up to 18 years. Get up here and do his little spiel, but I'd like to emphasize the fact that we've got several names for this disease. We know quite a bit more than we knew 2 years ago about this disease, but we're just in the beginning. This is going to be probably the disease of this decade or next decade. I believe it will be the disease of this decade. questions or just? Yes. Tech 99 bone scan is anywhere from $400 to $700. We don't get that. The hospital gets it.
If you see on an X-ray a picture that looks like the X-rays you showed, what's the likelihood of that actually being a NICO?
You won't know without doing surgery, but I warn you that osteomyelitis can look exactly like it, or my biopsy service, and I get maybe out of every 100, I'll get maybe 400 cases with pathology that's NICO before I'll get one that's normal or something else. I've picked up 3 cancers, 3 malignancies out of the first 3,000 specimens that were called NICO by the surgeon. And it wasn't until they got the path report back. 2 of them were lymphomas, 1 was a carcinoma. So when I say you have to be careful about that, I'm serious about that. I guess there's a forum toward the end, and we can take questions then.
Yeah, we will have a forum at the end, so hold the rest of your questions till then. Let's take a break. This is your exhibitors, and also remember the silent auction at the dams booth, so go visit them. Let's take 20 minutes.